The last study that I will review was conducted by Kim et al. And published in 2016. This study was conducted in the United States with the purpose to test the effectiveness of a community-based, culturally tailored behavioral intervention program in a minority group with type 2 diabetes mellitus on metabolic and self-care measures. After the review of the quality checklist by the Evidence Analysis Library, this study resulted in a positive quality. The intervention in question was group-based education of structured behavioral education programs, a previous curriculum entitled SHIP-DM, which involved 2-hour sessions once per week for 6 weeks, involving diabetes coping, treatment, risk factors, problem solving, belief in self, and health literacy. This education was provided by registered nurses and community health workers. The intervention was in comparison to a control group who received brief educational brochures highlighting the self-management principles of self-help for diabetes management. The study was conducted over a 12-month period. The outcome data in question related to blood serum measures, which were taken at baseline, 3 months, 6 months, 9 months, and 12 months. The results found a reduction of hemoglobin A1C greater than those in the control group, and the mean hemoglobin A1C changes were within the intervention group were significant at 3, 6, 9, and 12 months. The mean differences between the groups for hemoglobin A1C was also significant at each of the measurement intervals. In regards to fasting plasma glucose, the results indicated that there was a significant difference between groups at each interval as well, and you can see the specifics indicated in the outcome data column. The authors concluded that the results revealed the SHIP-DM curriculum delivered in group-based programs is effective in improving hemoglobin A1C and fasting plasma glucose in the ethnic minority group with type 2 diabetes. They noted that significant reductions were noted in both the intervention and control group. However, the magnitudes of the reductions in hemoglobin A1C were greater than those seen in other clinical trials. Here is a summary table of the hemoglobin A1C study results reported in mean standard deviation or mean only. Again, for the first study, the authors saw an improvement in hemoglobin A1C in comparison from the intervention and control. The second study saw a slight decrease, but their main objective was to see a reduction of at least 1% in the intervention group. Therefore, the results were not significant according to their outcome measures. The third study, while the baseline and conclusion measures were not significant, the mean values of hemoglobin A1C of the intervention group was statistically lower than that of the control group. And the final study, the one that we had just reviewed, revealed the mean difference of the intervention minus the control group. The hemoglobin A1C values were statistically different. And the second table is a summary of the fasting plasma glucose results, again reported as mean standard deviation or mean only. There were only 2 studies that reported fasting plasma glucose, and this was the first study conducted by Elia et al., who reported that at 3 months the intervention group had a significantly lower fasting plasma glucose. And in the final study, the mean difference between the intervention and control showed significant differences at each of the measurement intervals. In regards to clinical outcomes, the glycemic measures of hemoglobin A1C and fasting plasma glucose were the focus of this study. Hemoglobin A1C was measured in all 4 studies, but reductions were seen in 2 of those studies. The first study reported that there was a significant difference after 12 weeks from 9.7 plus or minus 1% to 8.3 plus or minus 1.3% in the intervention group. And you can see the p-value there. And the last study reviewed noted a significant difference over a 12-month period from 8.9% to 7.6% in the intervention compared to the control. There was also a significant mean difference in the intervention minus control in one of the studies, which was the final study, and the changes between the groups are noted in this slide here. The significant difference in mean value was noted in one study, and this was the study where the mean value was statistically lower in the intervention group when compared to the control group. However, there was no significant difference from baseline to the completion of the study. In regards to fasting plasma glucose, this was measured in 2 of the studies, and reductions were seen in both of those studies. First reduction was seen in the first study we reviewed, which was conducted over a 12-week period, and the other reduction was seen in the final study that we reviewed over the 12-month period. And you can see the reported significant differences listed here. There was also a significant mean difference between the intervention minus the control in one of the studies, and the changes between those groups were seen at the 3, 6, 9, and 12-month measurements. Here is a synthesis of the result, which is a table of the non-clinical outcomes of question in the systematic review. The aim of this study was to assess for effective elements of the group-based diabetes management education programs and common themes amongst session and program length, provider type, topic focus, and follow-ups were seen amongst the studies reviewed. At first, the session length was either 1 hour or 2 hours, and the entire program length ranged from 12 weeks in one study to 12 months in 2 studies. The provider type also varied amongst the studies, with providers of the education being nurses, community health workers, a registered dietitian and a nurse, or a nurse and a health worker. So 2 out of the 4 studies used a combined multidisciplinary approach to the education program. Another factor that also varied was the topic focus of the education program. It is widely known that diabetes is a multifaceted condition and therefore requires education in various aspects. And one aspect that the programs did have in common was that they combined multiple topics to discuss within their program. Some of these topics included self-care, insulin and medication, self-monitoring of blood glucose, diet and lifestyle, as well as complications of the disease and diabetes knowledge. At the top, you can see that self-care was one of the most common focuses of the education programs. And lastly, follow-ups was also utilized in two of the studies, and one of the studies used in-person follow-ups through individual counseling in combination with the group sessions, whereas 2 other studies utilized telephone follow-up calls. This brings us to the conclusions of the systematic review, and through the literature reviewed, it was revealed that group-based education for at least 12 weeks is effective in improving glycemic measures of fasting plasma glucose, as seen in 2 studies, and hemoglobin A1C as seen in 3 studies. One of the common factors of these programs that were reviewed through the randomized control trials was the duration of the programs that were at least 12 weeks in length, suggesting that 12 weeks is a good starting period for considering when developing group management programs. The aim of this systematic review was to identify the elements to consider when developing effective group-based programs, which include program and education session length, provider type, curriculum, and consideration of utilizing follow-ups, which were all discussed in the previous slide. Each program has variability and may be adapted to the different population. That's why these elements are essential to consider when developing these programs. The overall evidence grade for this systematic review is fair because although each of the studies included were of positive quality, there still are questions to be answered regarding the effects of group-based diabetes management programs on glycemia for larger populations. A sample size of 4 studies is not large enough to generalize to the general population. Therefore, additional research is needed. A few of the strengths of this systematic review is that the articles included were randomized controlled trials, which use blinding. Although each of the trials utilized single blinding, there was the use of blinding, which contributes to the validity of the studies. Most of the studies had a good retention rate, and each of the studies addressed the target population and outcomes of this research question. In regards to limitations, even though there was a good retention rate of the studies, the total sample size was fairly small, and that does not contribute to the generalizability of the results of this study. Additionally, this study limited the interventions to face-to-face group education. However, this likely excluded a large population of those who would do better with a virtual setting, because most people nowadays live busy lives and therefore need flexible interventions and forms of management in order to better take care of their own needs in addition to their family, work, and other needs. While the sample size was too small to be generalizable to a larger population, implications for practice still include considering elements of group setting, curriculum, program length, session duration, and provider type when developing group-based programs for adults with type 2 diabetes. It is also important to note that adapting the program to the target population is important, as each of these elements may differ depending on the population. Therefore, there are implications for future research to investigate through clinical trials of group-based education compared to individual settings, the elements of program duration, setting, provider type, and curriculum. It is also necessary to explore the effects of group-based education in face-to-face and virtual formats to include a larger population. Here are my references, and thank you very much for taking the time to listen to my defense of my Applied Nutrition capstone.